Thank you for joining this keynote speaking from Professor Michael Marmot. I'd like to highlight some of his career and outstanding records before we start the talk. Sir Michael Marmot is Professor of Epidemiology at University College London. He was a member of the Royal Commission on Environmental Pollution for 6 years. And in year of 2000, he was knighted by Her Majesty the Queen for services to epidemiology and the understanding of health inequality. Professor Marmot is a member of the National Academy of Medicine. So let's welcome Professor Marmot.
Thank you. Quality of life is often equated with some measure of happiness, well-being, or satisfaction. I'm going to make the case that health is a very good outcome measure of quality of life. The determinants of health and the determinants of other measures of well-being overlap. So that I'd like to argue that much of what I say about health, and particularly about health equity, the fair distribution of health, applies to other measures of well-being, happiness, life satisfaction. The second thing I need to say at the beginning, just in case there are any economists here, that health and health services are not the same thing. When the OECD, the World Bank, talk about investing in health, they don't mean that. They mean investing in health care. Health care does not equal health. I'm going to talk about the determinants of health. Health care is only one of the inputs. In fact, in my book, The Health Gap, my opening line is, what good does it do to treat people and send them back to the conditions that made them sick? Yeah, I'm a doctor, but when I talk to my co-professionals, that's what I say. What good does it do to treat people and send them back to the conditions that made them sick? And I'm going to talk about the conditions that make people sick. We're used to health getting better all the time. Rich countries, health just improves all the time. In England, something went wrong. For 90 years, from the end of the Great War, 1921 to 2011, life expectancy improved 1 year every 4 years. Now, just in case you're thinking, who cares about life expectancy? What do people care if they live another 6 months? Life expectancy is a very good indicator of the health of the population. So it's not that life expectancy per se, the length of life by itself, is the most important thing, but it's a very good indicator of the health of the population. So for 90 years, life expectancy improved 1 year every 4 years, 6 hours every 24 hours. If you worked for 6 hours today, you got it for nothing. Your life expectancy was as long at the end of it as it was at the beginning. That's amazing. And in 2011, it stopped. You can imagine the government was a bit threatened by this. What happened? Well, in 2010, we had a Conservative-led coalition government whose number one priority was austerity, fiscal rectitude. That's what they stood for. They got very defensive. You couldn't possibly be saying that it was anything to do with government policy that could lead to a slowdown in life expectancy. Well, I'm a careful scientist, and I said, no, I'm not concluding that austerity is killing people, but it is an hypothesis worth pursuing. And you see that dramatic slowdown. And in fact, later figures showed that life expectancy had more or less stopped improving in England, was declining for men in Northern Ireland, was declining for men and women in Scotland, and declining for men and women in Wales. And when we look at the social distribution, these are deciles of a measure of index of multiple deprivation. So these are areas. You can see for the bottom 5 deciles, life expectancy for women went down and didn't go up for men in the bottom 5 deciles. So the inequalities in life expectancy are getting bigger. It's not so bad if you're at the top. Life expectancy was still improving. It's not very good to be in the middle, and it's pretty rotten to be at the bottom. And you see what I call the social gradient in health. It's not just that poor people have worse health than everybody else, but it's a graded phenomenon. The lower you are in the social hierarchy, whether measured by income, education, occupation, area of residence, the lower you are in the social hierarchy, the worse the health. And the inequalities are getting bigger. Wow. And in the United States, life expectancy was declined 2 years in a row. Big increase in unintentional injuries, 2014, 15, 16. 63,600 deaths, and it includes accidental drug overdose. That's the epidemic of opioid poisonings. 2016 was 63,600. 2017, it was 70,000. Now, whether you want to have a debate about, well, is ill health the same as lack of satisfaction? Is the positive measure different from the negative measure? Let's have that debate. But if people are poisoning themselves with opioids, they're unlikely to have been very happy. And in fact, that previous slide said 2 years in a row, life expectancy has now declined in the US 3 years in a row for males and females. I said 70,000 deaths from accidental poison, 32,000 deaths from firearms. That's 100,000 deaths. Really, this should not occur. And life expectancy is getting worse. And if you agree with me that health is telling us something fundamental about the nature of society, of how we organize our affairs in society, then both in the UK and the United States, something is going wrong. There's the OECD aggregate, and there's the US. Back here in '97, the US looked like the OECD, but there's a diversion. So it's not the case that we've reached peak life expectancy, and it does have to slow down sometime, but it's not the case that we've reached the peak, because it's still going up in the OECD as a whole, but not in the US and not in the UK. And if we look at what's happened to inequalities in the US, this is a cohort analysis. Life expectancy at age 50 for men by year of birth and income. So people whose year of birth, 1920, were 50 in 1970. People whose year of birth was 1950 would be 50 in 2000. And you can see the gradient. The lower the decile of income, the shorter the life expectancy. There's the gradient, year of birth 1920, and 30 years later, the gradient's got much steeper. That life expectancy really didn't go up very much for people in the bottom 10% of income. went up a bit more for people in the next 10%. And then the higher the income, the bigger the rise of life expectancy. This is just the start of your conference. I don't want to put you off the rest of the conference. So are you feeling robust, resilient? I feel I should get informed consent before I show you the next slide. Get ethical approval. This is women. Oh my God. This is awful. Life expectancy is going down in the bottom decile. It's going down in the second bottom decile. It's going down in the third bottom decile. Life expectancy is declining for the bottom 30% of the income distribution for women. And the inequalities are getting very much bigger. Something is going wrong with the quality of life. And it's fundamental. And I know that because of the impact on life expectancy. Drug mortality, which I've referred to. This is a geographic analysis, and it's looking at economic distress geographically. And what you can see, the greater the economic distress, the higher the mortality from drugs. And then, doesn't need to bother us here, but they divide it into large metro, small metro, etc. But for all areas, the greater the economic distress, the higher the drug mortality. Parenthetically, these areas with high economic distress and high drug mortality also voted for Donald Trump. I think killing yourself and voting for Donald Trump were probably alternatives. I'm not quite sure which order people did it in. They killed themselves, then voted for Trump, or hadn't voted for Trump. What have I done? And took too many pills. And he may kill the rest of us. But it is saying something about the kind of dissatisfaction that leads to somebody having a drug overdose, also leads to voting for Donald Trump. Or, may I say, I was not going to mention Brexit. Or voting for Brexit. Our stable democracy in Britain has just collapsed completely. When I visit Italy, my Italian colleagues said, we know our politics is a joke. We used to look at you and think you had common sense. Gone completely. But it is some outcome of economic dissatisfaction. The Brexit areas, in general, were those with economic decline. That said, it was old, white conservatives who voted for Brexit. And stop it. My biggest beef about the Brexit vote is young people are overwhelmingly in favour of staying in Europe. And so old, white conservatives are depriving young people of their future. It's unconscionable. Do you get some feeling for where I stand on this issue? And one of my themes is that the mind is an important gateway by which social determinants affect ill health. We see effects on mental illness and well-being, suicide, drugs, alcohol, and the like, and psychosocial pathways to physical illness, impact on behaviours, and stress pathways. What is going wrong in the US? A steady decline in the percent of children who are earning more than their parents. So this is the percent of children who will earn more than their parents. In 1940, the child's birth cohort in 1940, 90% of children could expect to earn more than their parents. And the birth cohort of the 1980s, it's 50-50. So if the American dream was that work hard in a metal bashing industry and earn enough to send your child to college and own a cottage by the lake and have the fond expectation that your children will earn more than you will, that's gone. That's gone. And that might be some part of this explanation of what's going wrong. In the so-called Midas study, Americans of Midlife, if we look at the change in well-being from the 1995-6 to 2011-14 by socioeconomic status, negative affect for people in the bottom decile, negative affect was going up, but hadn't changed for people in the top 10%. Positive affect had gone down for people in the bottom 10% and had gone up a little bit for people in the top 10%. And you see the gradient. Life satisfaction gone down and you see the gradient. So the inequalities in these measures of well-being were increasing. That well-known medical journal, The Economist, interesting graph that they just published. Most Americans expect life to get worse. And as The Economist says, there may be justification for some of their fears. Race relations improve or get worse. So terrorist attacks as bad as 9/11, the blue expect to get worse. Public education, America's economy, healthcare, America's role in the world, politics in America, living standards in America, and the gap between rich and poor. Overwhelmingly, Americans expect all those things to get worse. So I'm making this link between subjective measures of satisfaction, well-being, and what's happening somewhat more objectively to health. What can we do about all this? I talk about social determinants of health. I chaired the WHO Commission on Social Determinants of Health. We published our report in 2008, and we called it Closing the Gap in a Generation. In the wake of the Global Commission report, I was invited by the British government to do a strategic review of health inequalities in England to answer the question, how could we apply the findings of your Global Commission to one country, England? And the so-called Marmot review was published in 2010. We then did a European review of social determinants and the health divide for the European region of WHO. And on the 1st of October, in Washington, DC, we will publish the report of the Commission of the Pan American Health Organization of Equity and Health Inequalities in the Americas. This is from our PAHO report, the so-called Preston Curve, which you may be familiar with, for countries in the Americas, looking at GDP per capita and life expectancy. And it has an interesting shape, which I think is highly relevant to the discussion of how do we want to measure societal progress? Is national income a good enough measure? Well, at low levels of national income, a small increase in income, this is adjusting for purchasing power, a small increase in income is associated with a big increase in life expectancy. So, if as a country you're as poor as Haiti and you get somewhat richer, rich as Bolivia, it is reasonable to expect that life expectancy will improve. And if you go from Bolivia to Brazil, get richer still, life expectancy will improve further. And if you become as rich as Costa Rica or Chile, life expectancy will improve further. I left Cuba out because I don't know what the national income of Cuba is. But we have a fair idea what Costa Rica and Chile are. Then if you go all the way out from Costa Rica, Cuba and Chile to Canada and the US, there's no relation between national income and life expectancy. In fact, the US has 20% bigger national income, but life expectancy that's 3 or 4 years shorter than Canada. So for a country, if you're a poor country, getting richer is quite helpful for improving health. But when you get up to the level, adjusting for purchasing power, of about $17,000 per person per year, Costa Rica, Chile, possibly Cuba, then going all the way up from 17,000 to 60,000, the US figure, is not associated with an improvement in life expectancy. Other things become more important. And look at this. The United States and Costa Rica, inequalities in mortality now, not life expectancy, in mortality. There's the US and there's Costa Rica. So if you're lower socioeconomic status rank in the US, you can expect higher mortality than being lower SES in Costa Rica. Just keep that figure that I mentioned for Costa Rica, $17,000 per person, adjusted for purchasing power, in your head for a moment. Because I want to talk about Baltimore. In Baltimore, the poor area of Baltimore, life expectancy for men is 63. In the rich area of Baltimore, it's 83. If you live in Roland Park, the rich area of Baltimore, and you want to see what it's like to live somewhere where the life expectancy is 20 years shorter, you could get on a plane and fly to Ethiopia. Or alternatively, you could go a few kilometers across town and see what it's like in Upton Druid. Life expectancy 63. And median household income was $17,000. The same as in Costa Rica, because we were adjusting for purchasing power. Life expectancy in this poor part of Baltimore is 63 for men, and in Costa Rica it's 77. The same income and a 14-year difference in life expectancy. It's not just income, it's social conditions. And some of the differences, half of single-parent families, 90% did not go on to college. And I want to talk about something else. Forgive me for introducing a second idea. I know that's a bit dramatic to have 2 ideas in one presentation, but I'm sure you can do it. Let's try and keep 2 ideas in our minds. And the second idea is crime and civil unrest. Because in fact, I was giving a seminar about my book, The Health Gap. Did I mention my book, The Health Gap? In the US. And just before I was giving the presentation, Baltimore erupted in civil unrest. And when I say Baltimore erupted, that's slightly inaccurate. Upton Druid erupted. The precipitant for the civil unrest was the killing of a black man by the police. Or should I say, one more killing of a black man by the police. That was the precipitant. But the underlying cause was inequality. And you can see that in this poor part, each year, a third, aged 10 to 17, are arrested for juvenile disorder. A third each year arrested. means a criminal record by 17 for most. In theory, the slate is wiped clean at 18. Somebody asks you, you go for a job, somebody says, have you ever been in trouble with the police? You could lie. That's not a very good qualification for a job. Well, could make you Prime Minister of the United Kingdom. But he's not looking very healthy at the moment. He's getting into a bit of trouble with his lying. Or you could tell the truth. Yeah, I've been in trouble with the police, and that's not a very good qualification for getting a job. And 100 non-fatal shootings for every 10,000 residents, and nearly 40 homicides. And in the rich bit, two-parent families, median income $90,000, not 17. They go on to and complete college. And juvenile arrests, not 1 in 3, but 1 in 50 each year. And no non-fatal shootings and 4 homicides, not 40 per 10,000. Very different. Now I want to go from Baltimore to Alice Springs in Australia, in the Northern Territory of Australia. Now, if you think, as I did when you arrive in Alice Springs, that this is a very tiny place in the middle of the Red Desert in Central Australia. And then I was taken to an Aboriginal community, Indigenous Australians, in Arayunga, 2 hours drive from Alice Springs, a thriving metropolis of 200 persons. This is downtown Arayunga, council office, the health clinic, and the store. But coming back to Alice Springs, there's one big building, the Supreme Court. Towers, it's even bigger than the hospital. Normally you go, the biggest building's the hospital. This is the Supreme Court. In Arayunga, there is no economic activity at all. There's nothing for young people to do or to look forward to other than getting up to mischief. And when they get up to mischief, that's where they find themselves. And if you look at Indigenous Australians in the Northern Territory, the incarceration rate is 240 per 100,000. For non-Indigenous Australians in the Northern Territory, it's 186. It's a 13-fold difference. 84% of the prison population in the Northern Territory of Australia is Indigenous, compared with 27% of the general population. And now I'm getting to my point. Diagnosed mental illness in prisoners, 72% in young men, 92% in young women. Can you think of a worse place to put damaged young people than in prison? You take a young person with mental illness and lock them up in prison? What will that do to their well-being? And given this overwhelming prevalence of mental illness among prisoners, it could be that being locked up causes a deterioration in mental illness. But indeed, many, perhaps a majority, have mental illness, which is what gets them locked up. So we need to look at the social determinants of mental illness and the social determinants of crime. They're related. And parenthetically, the incarceration rates in the US are over 700 per 100,000. In the UK, 140, and in Japan, 40. So if locking people up is damaging people, wow, you can see why the US might have a problem. And I had a quick look at the literature, somewhere between 10% and 80%, depending which studies you look at, of people who've been locked up in prison have mental illness of some form or another. So it's not just Indigenous Australians in Denmark, in the UK, and the US. Therefore, prevent mental illness in children. It'll be good for their mental health, their physical health, I venture to suggest for their well-being, and will reduce the incidence of crime and getting locked up. In my English review, the Marmot review, we had 6 domains of recommendations. Give every child the best start in life. Education and lifelong learning. Number 3, employment and working conditions. Number 4 was really radical. In a rich society, everybody should have at least the minimum income necessary for a healthy life. 5, healthy and sustainable places in which to live and work. And 6, taking a social determinants approach to prevention, smoking, drinking, diet, physical activity, drugs, and the like. Give every child the best start in life. What we've got here is a measure of good early child development. Look first at the blue dots. Don't look at the red dots for a moment. This charts the percent of children aged 5 with a good level of development for each local authority in England, classified by degree of deprivation, the index of multiple deprivation. And what you see is the more affluent the local authority, the higher the proportion of children aged 5 that have a good level of development. What you also see is their scatter around the line. For a given level of deprivation, some local authorities are doing better than others in terms of early child development. Now, look at the red dots. The red dots are children eligible for free school meals. It's a means-tested benefit, so they're the poor children. Good heavens. The slope is going the other way. That's not what I expected. Like any scientist, when you find things you don't expect, you try and get rid of it. I said, we made a coding error. Let's do it again. Suppress it. But it kept coming out. Poor kids are doing better in poor areas than they are in rich areas. And I think the answer is that if you're a poor kid in a rich area, everyone else is leaving you behind, and the teachers don't care. If you're a poor kid in a poor area, you're in the majority, because there's so many of you. And I've been to some of these poor areas where the poor kids are doing well, and the teachers say to me, what we do in our day job is try to break the link between deprivation and poor outcome. That's what we do. Hey, this is pretty encouraging. Don't for one moment think that poverty is destiny. You can break the link. That's what they're doing in the London Borough of Hackney and the London Borough of Tower Hamlets. They're breaking the link between deprivation and poverty, between deprivation and poor early child development. The other way of dealing with that social gradient is to reduce child poverty. This is from UNICEF for the rich countries. Poverty is defined as less than 60% median income. In Denmark, 9% of children are in poverty, Iceland 10%, Norway 10%, Finland 10.9%. There's the UK, 19%. There's the United States, 29%, just below Mexico. You could change that tomorrow. The Minister of Finance has the levers in his hand, and it's usually he, ministers of finance, they allow ministers of health to be women, but the minister of finance always a man. Maybe that's some of the problems we have. But he has in his hand the lever that could change child poverty tomorrow. In the US, I say to my American colleagues, you live in a democracy. This must be the level of child poverty that you want, or you'd elect a government that did something different. And they say, we're not going to invite him back. And yeah, I guess the US doesn't have enough money. This is the tax revenue as a percent of GDP. France is up at around 46%, and the US is below 30%. So in other words, the US is saying, we're quite happy to have children grow up in poverty. That orange nightmare in the White House that keeps boasting about this is the best that it's ever been, does he know about this? Does he care about this? So the good side of early childhood is nurturing, promoting good early child development. The bad side are ACEs, adverse child experiences. And adverse child experiences follow the social gradient. The more deprived, the greater the frequency of adverse child experiences. So they're making a contribution to these poor outcomes. One way, of course, of dealing with poverty is to work, go out to work. And certainly much of the political rhetoric has been blaming poor people because they're lazy, they won't get a job, they're relying on welfare. In Britain, the majority of people in poverty have at least one member of the household in work. So they're workless households, and they're households with at least one member in work. The reason these people are in poverty is not because they're lazy, not because they're irresponsible, but because they're lowly paid. That's why they're in poverty. If they were paid more money, they wouldn't be poor. And when we look at some of the consequences of low income, well-meaning people like me say to poor people, you should eat well. Eat fruit and vegetables. Stop eating all that rubbish. Eat good food. For people in the bottom 10% of household income in England, if they followed the Public Health England healthy eating advice, they would spend 74% of household income on food. Forget all that good advice that people like me are saying. If they ate healthily, they couldn't pay the rent. And if they paid the rent, they couldn't heat the house. They can heat or they can eat, but they can't do both. And that means that characteristics of housing and neighbourhood matter for health, because neighbourhoods matter for health, but housing is a food issue. Look at this, childhood poverty in London, less than 60% median income. Before housing costs, 17% of children in London are in poverty. And after housing costs, it's 37%. The cost of housing is driving people into poverty, and if you drive people into poverty, you can't expect them to eat healthily. I went to an exhibition. I used to be a serious scientist. Now the Lancet medical journal sends me off to photo exhibitions to write reviews for the Lancet of plays and books and photo exhibitions. I quite like it, actually. So I went to an exhibition of bedrooms of London. Bedrooms of London. London has more billionaires than any other city on the planet. And this is how children are living. Emily and Martin and their babies sleep on the sofa bed in the living room where they eat, the other 3 children in the bedroom. Martin earns £800 a month. Outside, older kids compete for drug clientele. They leave knives in the bushes where younger children play hide and seek. 2 double bunks in that room. 3 teenagers and a 9-year-old in one room, mum and dad in the other. Both parents work, but they still have to have their rent subsidised. So the rent is subsidised to live in that accommodation, with both parents working. The area is full of gangs, says the mother. I want my children to live in a safe place. There are kids around the building who don't go to school. I call this one everything and the kitchen sink. Look at the size of this room. The cot, the distance from the bed to the door, the sink. Amelie's partner left when she was 5 months pregnant. And Amelie, the mother, said, at the beginning I didn't have benefits, so I didn't have food. I was crying for no reason. Crying for no reason. She puts a towel under the door to stop the marijuana smoke from getting in. A Nigerian mother with an English father and 3 children in a 2-bedroom flat, and she said, to know that somebody somewhere is making something available for you to be happy. My feeling welcome in this country has been all through charities. Are these mothers and their children, are they feckless? Are they choosing the easy life of welfare dependence, as some of our political commentators think? And one mother said, nobody falls into this on purpose, because your whole life is going to be a trap. A trap. And then you will see yourself living a life you never thought you would. This is in London with all those billionaires. But the good news, the city of Coventry declared itself a Marmot city. They took my 6 recommendations from the Marmot review, said, we're going to do it for Coventry. We're now working with Greater Manchester. They said they want to be a Marmot region. I said to the chief executive of Manchester City Council, I said, my wife asked, could you not call yourself a Marmot city? My wife thinks this is egomania. So could you call it something else? And this chief executive said, I'm sorry, we're using that language. People understand what we mean about a Marmot region. I said, could you please write to my wife and explain? I daren't go home. I spent a year as president of the World Medical Association, which is pretty odd, and this is not false modesty. I've spent my whole life saying that the key determinants of health are not what doctors do for patients. It's the social determinants of health. And then I found myself president of this organization of doctors and medical associations. So I reminded them, what good does it do to treat people and send them back to the conditions that make them sick? And my 2 messages in a world of post-fact politics was evidence-based policy presented in a spirit of social justice. I reminded them that we said on the cover of the report of the Commission on Social Determinants of Health, social injustice is killing on a grand scale. When we were doing the PAHO report, I went for a walk in the mall in Washington, D.C. For those of you who don't know the geography of Washington, D.C., the mall is that area of the capital that was sparsely populated during Donald Trump's inaugural, much to his upset. And Martin Luther King said, I believe that unarmed truth and unconditional love. I thought, unarmed truth, yeah. Evidence-based policy is a bit more prosaic, and spirit of social justice is not quite as poetic as Martin Luther King. But he said, I believe that unarmed truth and unconditional love will have the final word in reality. This is why right, temporarily defeated, is stronger than evil triumphant. I believe that with all the rotten things going on in the world, right, temporarily defeated, is stronger than evil triumphant. Let me come back to Australia to finish. I talked about the Northern Territory. Life expectancy for Indigenous Australians, 10.6 years shorter for men than non-Indigenous, and 9.4 years for women. Huge health gap. I was taken to a shed in Western Sydney, and the purpose of this shed was to prevent Aboriginal men committing suicide. The founder of it, he said, the conventional wisdom is that men get depressed and suicidal because they won't talk about their feelings. We took the view that men get depressed and suicidal because they're homeless, because they're in poverty, because they're unemployed, because they've had their children taken away from them, and they get involved in drugs and alcohol and domestic violence. So we're trying to deal with the social determinants of suicide. And I was told these horrible stories of child removal, isolation, depression, and indeed death, suicide. But this organisation is trying to deal with these determinants, as is this area in the south of Sydney, the Tharawal Aboriginal Corporation. The popular belly cast program. Aboriginal women don't attend antenatal classes. The way they got the Aboriginal women from these communities to come was they had this belly cast program. They took plaster casts of their pregnant torsos and decorated them with Aboriginal art. Gorgeous, absolutely gorgeous. And the women love it. So they come in, and educational gatherings before pregnancy, during pregnancy and after birth. So they're hooked. This becomes their centre. And their children then come to the centre. And each of these programs has been evaluated, Triple P parenting, 1, 2, 3 magic, grassroots parenting, to improve early child development. Drugs and alcohol, they have a whole part to deal with the problems of drugs and alcohol. And, I don't know if you can read that, grannies against removal. Children are being removed from their families. The default position of the child welfare system in Australia is that Aboriginal parents are not able to care for their children, so they're removed. And these older people, grannies, grandmas, against removal, keep our children with us. It was really inspiring. I was in Australia, and the reason I went to visit these places, because I was giving some lectures for the ABC, the Australian Broadcasting Commission, Australian version of the BBC. And before my lectures, a way of trailing it, I was on the television current affairs program, questions and answers, and I talked about income at the invitation of the convener. And I said, what do the following have in common? The 48 million people who make up the population of Tanzania, the 7 million people who make up the population of Paraguay, the 2 million people of Latvia, and the 25 top-earning hedge fund managers of New York. And the answer is, in the previous year, each of those groups had a combined income of around $25 billion. Imagine, I said, that the hedge fund managers gave up their income for 1 year. They wouldn't miss it. They're going to earn $1 billion each the next year. And you move that to Tanzania, you double the per capita income of Tanzania. And I wasn't suggesting you simply give it to individual Tanzanians, but imagine the clean water you could pipe to the villages, the teachers you could employ. And one of my fellow panelists said, "You're in fantasy land, mate. Complete fantasy land. That's never going to happen. You're talking about redistributing income. You're in fantasy land." And it was the next morning that I went to the Tharawal Community Centre, and I was greeted by one of the doctors holding a sign. So I say to you, welcome to my fantasy land, and let's dream of a fairer world.
Thank you. That's a wonderful talk with you. We still have 10 minutes for a question from the floor. It's a precious opportunity to ask a question. Okay.
I was wondering why are women affected by...
I was surprised by the fact that women are being more affected by the decrease in life expectancy, because typically they are above. So what are the explanations?
Yeah, the easy answer is I don't know. But you're right to spot it, because in general, the inequalities in health are bigger in men than in women. When we look across Europe, for example, Russia has much shorter life expectancy than the Nordic countries. The gap's much bigger for men than it is for women. When I look at the inequalities within Britain, in general, the gap's bigger for men than it is for women. So I'm mystified. I really don't know the answer, and I'd like to. So that's not very satisfying, but yeah, I'm pleased you spotted it, and I can't answer the question.
Research. Thank you.
Thanks very much for, I won't say inspiring, but because that would be doing injustice to what you described.
Just, could you?
The one thing I was curious about when you were describing the decline in life expectancy in the UK is you also showed that Scotland's numbers were going down. And I know certainly in the period from about 1990 to the current, that they tend to have a more social justice or social well-being framework that they're using. So I was with a real focus on community development and so on. So I was wondering what would account for their decline.
Yeah, so I'll come back to it, but one more thing I should say about your question, that although the increase in inequalities is bigger in women in the US and the UK, it's still the case that women have longer life expectancy than men. So the female advantage has been reduced a bit, and the inequalities are still bigger in men than women, but the female advantage has been reduced a bit. So it's not that it's a complete reversal. It's still a good question. And to come back to Scotland, what's interesting, I have a good colleague in Scotland who, in fact, for a while was the Chief Medical Officer of Scotland, Harry Burns. And Harry says, I'd like to think that Scotland is like a Nordic country. Well, I think that's wishful thinking, because in fact, the inequalities have always been big in Scotland. I've written about Glasgow, and you read what it's like to grow up in a poor part of Glasgow, it is really miserable. And I talk about Baltimore. In Glasgow, at the time we published the WHO Commission report, the life expectancy gap between the poorest part of Glasgow and the richest was 28 years. Life expectancy for men in the poor part of Glasgow was 54, and it was 82 in Lenzie. So they've got these huge embedded inequalities in a post-industrial society that has just not benefited the way, for example, the southeast of England benefited from a transition to a service economy. So huge problems, even though the politicians and the technical people like Sir Harry Burns very much understand equity, social determinants of health. They've got a lot of problems that they have to address.
But not to argue, but we started by pointing out that in the UK you had a period of austerity imposed as of 2011. As far as I know, they didn't do that in Scotland. So indeed, they're always going to be lagging the UK, but you should have seen.
They did do it in Scotland because they were still dependent on Westminster. I was at a meeting in Edinburgh, and I said to the head of the health and social care, I said, these ministers are terrific, you know, they're talking this wonderful language. He said, yeah, because they haven't got their own budgets. Wait till they get their own budgets, then they'll be talking a different language. So they were still getting, or not getting, money from London. So they were suffering from austerity.
Sorry, Michael, I'd like to add to that. I'm from Scotland. I'm Londoner, as you can probably guess from my accent, and I live in Scotland. The key point, the key reason is, yes, the Scottish Government is struggling for social justice, but we don't have our own control over tax and benefits. So the austerity has hit in Scotland exactly the same as anywhere else. So the Scottish Government can do little bits on the edges, but it can't do actually very much to alter the underlying economic circumstances.
And I wasn't going to mention Brexit, but you know, one of the effects, Scotland is very outward looking. European, got one of the more impressive political leaders in the United Kingdom, in Scotland. And the UK could break up, and Scotland could apply to be a member of the European Union if Brexit goes ahead.
We have one question here, and this question there, just, okay. Oliver first, and then, okay, go ahead.
Thank you. I'm Oliver. I'm coming from Estonia, University of Tartu. And my question is about teaching future doctors. So it's inspired about that you were this association's president. That actually in Estonia, University of Tartu, I'm a bit involved in teaching future doctors in the university, and there are one course when we also teach them about these health inequalities and social determinants of health and so on. And it seems that these types of things are not so, I don't know, important for them, or they don't feel that it is so important. The important is that, you must know what bones are where and so on. Real stuff, but it's, okay, I must learn it. But yeah, my question is, have you ideas how to change the schooling of future doctors? Or, yeah.
Well, it's a good question. I have to make a confession here. I have this condition, which I hope is not fatal, which is that I'm optimistic all the time. And there's obviously something wrong with me. As I say to doctors, there must be some pills I could take for this condition, but I'm just optimistic all the time. So when I deal with the medical profession, I see all these good things happening. And I don't see all the people who are ignoring the message. I see young medical students really excited, actually driven by equity, social justice, the reason they come into medicine is because they want to make a difference. And they see poor people suffering, poor health, because of their poverty and their social conditions. They want to make a difference. Now, what happens, of course, is they get rightly entranced by the spellbinding science. And it's fantastic. What we're doing in biomedicine and science is fantastic. And they get attracted, of course. And, immunotherapy. But I lecture to first-year medical students. I get them in their so-called pre-cynical phase before they're getting. And I talk about, for example, minimum income for healthy living. And I say the calculations we did for older people, how much money do you need to have a healthy life? Well, what do you need for diet and so on? But we also include buying presents for your grandchildren. How can you have a healthy life as an older person if you can't afford to buy presents for your grandchildren? And I say to these medical students, you came to University College London because you wanted to learn about genomics and metabolomics and proteomics. And here's this lecturer saying, if your granny can't afford to buy you a birthday present, she can't have a life of dignity. And they love it. They love it. In fact, I was telling a story like this to the chief executive of one of the charities, and he started to cry. And he said to me, I only found out recently that my own grandfather would go without meals in order to buy presents for his grandchildren. Medical students go, in my experience, go and study medicine because that's what motivates them. They're interested in science. And then, of course, some get interested in money and status and all of that. But I'm not cynical. Most of them are interested in improving things for patients. And what the message we're trying to give is that should include improving things for the societies in which they live. That will improve things for patients. So, for example, I've been working as undergraduates in Britain with the medical Royal Colleges, with the Royal College of Physicians, the Royal College of Paediatrics and Child Health, the Royal College of Psychiatrists, the Royal College of General Practitioners, the Royal College of Obstetrics and Gynecology, and public health, occupational health, and trying to get the teaching of undergraduates and postgraduates to include social determinants and health equity. We will make a difference.
Thank you for your question, which will be the last one.
Okay. Thank you very much. My name is Yvonne Rodriguez. I'm a master's student of public health, and my bachelor's is medicine. And, well, actually my question is related to, in the same line of the question before, because I would like to know in which way will you raise awareness of not treating only people, in the way of making conscious about the social determinants, because from my point of view, I think they are really broad and at the same time kind of external from us, that I don't see now, like in which way, how can I try to tackle social determinants, for example? Because unless we are a high officer of the government, or unless we are, like, as you said before, like Prime Minister of Finance or Minister of Health, I really think that it's complicated. Thank you.
Well, my message to medical associations when they ask you a question, we're doctors, we treat patients. What do you want us to do about social determinants of health? And I said 5 things. Education and training relates to your question. Second, see the patient in a broader perspective. And that relates to being a good doctor. If your patient is homeless, what's the point of treating the pneumonia or their leg ulcers or their alcoholic problems and sending them back to the street? You've got to deal with the fact of their homelessness as well as treating the consequences of their homelessness. The third is the health service as employer, and I would actually generalize it and say the health system has impact on the community, environmental impact as well as social and economic impact, but also as employer. The fourth is working in partnership. So pediatricians understand this. They understand the inputs into good early child development. Geriatricians understand this, that it's not just what the doctor does for an older person, it's the conditions in which that old person lives. So, working in partnership. And the fifth is what I'm doing here. Advocacy. Arguing from the evidence to improve conditions for the patients and the communities that we serve.
Okay, I'd like to thank Professor Michael Marmot for his sending us the idea of fantasy land. It's real utopia. We are likely to have to realize with our research and efforts. So please join me to thank Professor Marmot again. Thank you very much for inspiring us. Thank you.